So I think just the mental state, I think being happy helps, I'm sure, because I think there is given that it is so linked to our hormones, and just being grateful for whatever life is given and being in a state of kind of some satisfaction that I'm sure puts the body at ease. And that's, I don't know if it is easy to measure such things, but I think these things are important. Yeah.
Basically, accepting the fact that you are having a problem, whether it is the male or the female. Once you come to terms with the fact that, okay, yes, we are facing an infertility issue and we will get help. And there are specialists who can help us. That is the first step, and it will go a long way towards addressing the stress that the patient is dealing with.
Yes.
So having a stressful environment, we always tell them that, you can be as stressed as possible. It's not going to help you.
It's not going to help.
It is only going to worsen your situation. Because when you are stressed, all your reproductive hormones go haywire.
Yes.
So be relaxed and trust in the doctor you are taking treatment with.
Absolutely.
And hope for the best.
Oh, absolutely.
What is it, Deepalji? I will call it as vitamin H. Vitamin H.
Yes.
And vitamin G is gratitude. Every day, be grateful for having woken up in the morning, having all the facilities you have. And that kind of a thing, they said it helps more than, like taking
just
supplements and all
medicine.
that.
Yes.
And also, the interaction between the patient and the clinician, doctor. When she comes in for the first time or when she repeatedly comes in to see you, that also eases them out, Yeah. So, when you are at a mental state where you are happy yourself, then, and you pass on the same,
True.
vibes to the patient, then definitely they go out, with a positive state of mind. And the one word that, you will have a baby does wonders to them. So,
Oh, yes.
a kind of interaction where you are attaching yourself to them emotionally. As you said, it's a very big emotional, clinch. And
I
that
can't
has
think
to
of
be
a bigger
there.
emotional.
Yes. So if somebody says, okay, I'll help you out, don't worry. That little, thought there and just passing that vibe to her or him, they just go out of the room so happy, They say,
Yes.
thank you so much, madam. You've eased out us with the tension we came in.
Totally.
You've just eased us out, So, and then the next time when they come to you, they are at a much more relaxed state of mind, and then,
Able to-
the happiness coefficient is definitely higher than what it was when they came to you. So I think
Absolutely.
that talk with them, to ease them out. They could be clients from a very high strata to a very
Right.
straight up. But then
Absolutely.
everybody needs that kind of, a talk wherein, yes, you can, sail through this.
At the same time, we have to be realistic.
Totally.
Also tell them that this is your problem. See,
Yes.
your sperm count is zero. Like
Yeah,
sometimes
yes.
You will feel bad.
You
to
just have to
convey
be
that, but
honest with them.
It's like conveying a bad news, but we have to be vocal about it.
Yes.
We have to tell, see, it's zero now. Whether I can get this sperm from the testes or not, I don't know. So even those things we have to tell them. The bad news as good news.
Yes.
And then you tell them the options, like these are the options available to you. Give them the practical hope that, okay, this is the option and this is how you will conceive. A lot of them will agree to it and then
Yes.
move forward. A few of them are very, kind of people who don't really want to accept this is my problem. They shy away or they move. They don't really want to be into the practical.
That's right.
Yeah, but then those little, numbers will always be there in any,
In any
so
space.
those people also, you can help them, but then it's up to them to take that, But definitely,
Take
as a
that
clinician,
step.
you can play a big role,
But when you offer options, Dr. Grover, I think that's a very interesting thing, interesting segue. So I keep seeing new technologies come into this space. And I'm not sure how much patients understand these technologies. So when I'm sure there is more than one way to help a patient when a doctor wants to help. So how do patients choose, or how do you choose that out of these 6 options, I think this one is the most suitable? And
Again, it comes down to, whether it's the female who's having an issue or the male who's having the issue, So mostly women, now with the recent trends coming in, with women coming into fertility treatments a bit late, after 30, 35, mostly after 35 or even in the late 40s or early 40s, then the focus totally goes on to the, the ovarian reserve, the egg quality, as madam has just discussed. So what we try and tell them is, now the AMH levels, the first thing that we assess them through is the AMH levels. If the AMH levels are lower than a particular level that is less than 2 or less than 1.5 nanograms, as she said, then we have to be very realistic, very practical to the patient. Tell them, okay, these are the number of eggs that you are left out with. Now if you need to hasten up your fertility journey, you can't just wait. You can't even wait for a couple of months, because all these, they say you lose 30 eggs per day. That's the way your eggs you're losing, So if you can just put them across that okay, this is the way your fertility is declining, then they become very proactive. Second thing is, give them the treatments which are now latest in the the infertility scenario. Like now we've come up with a lot of regenerative medicine. Now a lot of cases have been reported, and people are doing it. In our center also we've been doing cases in a lot of numbers, wherein the ovarian reserve is like the egg quality and the egg number is coming down. So we are offering these newer latest treatments wherein the stem cells have been aspirated, processed, and then we've been injecting into the ovary, okay, on a regular basis, and when again assessing their fertility status. So these are all latest treatments which we are offering to women who are actually in a state where the ovarian reserve is coming down, or probably on the report is too low. So practically this is how it is happening, and yes, obviously if it is too low and she's gone into a state where the ovaries have failed, then she has to be counseled about the option of an ovarian oocyte donation, which is wherein she takes a donor, which is she takes an oocyte donation from a younger woman where the egg is healthier, where the egg numbers are more. So that counseling also comes in, because that's something which we'll have to tell her, okay, this is the result with your own egg, this is the result with a donor egg.
Yes.
And this is the reason why your egg reserve has come down, what is the reason behind it. After trying it with these treatments also, if she doesn't have a good ovarian reserve, then the option of oocyte donation, or if she's failed multiple times
Yes.
with her own egg, then she would definitely want something more result oriented. And then she will say, madam, why don't we sometimes patients also come and tell us, okay, I've failed multiple times, what do you
Yes.
suggest? So then it's very right to tell them, okay, you please go ahead with taking an oocyte donation, which is quite streamlined now.
Yeah. No, that's very interesting. So, Dr. Kiran, when do you suggest surrogacy to anybody?
Just to tell you an anecdote, earlier and all, whenever the people used to prepare for a lecture, so this last line used to be surrogacy. So everybody knew that it's not possible. Like now how we talk about a uterine transplant.
Yes.
We say take somebody's uterus and put it, like that. So it is just comes in the last, small words. So that scenario has totally changed now.
Yes.
So earlier it was not streamlined, the surrogacy, people were not streamlined, the social agencies were not there, and people didn't have that much experience also of keeping them, of taking care of the surrogates, and streamlining the whole process. So now down the line, maybe another 20 years passed, and then we started saying surrogacy as the first option for whoever has this, like if you have failed 3 times in your IVF. If your uterus is non-functional, you have a uterus but the endometrial lining is non-functional. You don't have a lining which reaches to 8 millimeters on the day when I am going to put the embryo there. So if it is 6 millimeters and repeatedly I am trying, I'm wasting her money, I'm wasting her money, I'm wasting my effort, and I'm making her, all the more depressed and all. Saying that she would say I'm not capable. And slowly, as time passes, her eggs also may finish off, and then she comes to us at 40 and says, do a surrogacy with my eggs. It will not be
possible.
So earlier, rather than offering it as the last option, now we started offering it sometimes even in the first and second consultation. Not that like it has some other bearings like the economic reasons or some other reasons and all, because surrogacy also is a very complex process. You have to have sometimes 1 or 2 attempts also. You have to find a suitable lady.
Yes.
You have to find you have to take care of her health during those 9 months of pregnancy. You have to ensure that she has a healthy baby. You have to ensure that the baby is chromosomally normal. So many things I can tell you that which I need to do. And ethics wise also our whole ethical committee should agree for that. We have an ethical committee within our hospital. So all of them, they say okay, to take my opinion, take other doctors, and Samit also says say okay, this is the patient for surrogacy, then I think we should not.
Go ahead.
We should definitely tell them, and you won't believe that so many patients themselves are coming forward. So many patients are coming forward because they are seeing from the media or their
Yeah.
relatives or their friends or something, or the celebrities doing it. Everybody is coming and saying, now you put it there. We have had enough. Let me do it.